We are in.
We're in. Okay, I think we've just opened the gate. So welcome everybody to this International Collaborative webinar. My name is Professor John Ellershaw. I'll be giving the talk today, and the focus is on the role of volunteers at the end of life, and focusing on the results of the EU Horizon 2020 iLIVE project. So just a few words about the collaborative before I start. The International Collaborative has got over 700 members from 6 continents around the globe. And our vision is a world where all people experience a good death as an integral part of their individual life, supported by the very best personalized care. So what do we do? Well, you're going to be hearing about our research and development in a moment, including working with EU grants, but also on a smaller level at national and local level about research and development, about learning and teaching, and also quality assurance. And underpinning that is a 1040 model for best care for the dying person that links that expertise up into supporting documentation at the bedside of patients to deliver the best care for the dying patient. This year, we're very excited to join forces with the EAPC, and we have a task force now in the EAPC for care for the dying. And that work includes a multi-professional network and forum. It includes inviting EAPC members to our webinars, including them in newsletters and the website, and promoting sessions at each other's international meetings. And over the next 3 years, we'll be developing a white paper for the EAPC on best care for the dying person. So back to today's presentation on the role of volunteers at the end of life. So what I'm going to talk about today is the development, implementation, and evaluation of an international training program for hospital palliative care volunteers in 5 countries. Following my presentation, we're going to have a panel discussion, and that will be introduced by some reflections, first by Tamsin McGlinchey as a researcher who has worked on this iLIVE project and volunteers, and also by Greta Skorpen from Norway, who has worked as a volunteer coordinator, who has developed the volunteer service and the evaluation and research in Norway, in Bergen. So within our this project has been part of a larger iLIVE project, an EU Horizon funded project, a large cohort looking at what influences how and where people die and their preferences. But embedded in that large cohort study has been a project around volunteers' support in the last days of life. And that's the aspect of the iLIVE project that I'll be talking about today. In the autumn, Professor Agnes van der Heide, who has led the iLIVE project, will be talking about the cohort study and the wider findings of iLIVE. But today we're going to focus on what's been Work Package 3 around the volunteers. And the focus of the study was to develop, implement, and evaluate an international training program for hospital palliative care volunteers in 5 countries. These are the 5 countries involved. And this project plan, you don't need to read every line of this, but this is what I'm going to talk to you about today, about the project that we've run over the past 5 years. And the first part of that was establishing a hospital volunteer service. Of the 5 countries, only the UK site Liverpool, the Royal Liverpool University Hospital, had a hospital volunteer service in place. In the other 4 countries, there was either no end-of-life volunteer service, and in some, no volunteer service at all. So the first steps were to develop a European core curriculum for hospital end-of-life care volunteers, deliver an international training program for volunteer coordinators, and develop a learning lab for volunteer coordinators. So to develop the European core curriculum, we undertook a Delphi study including a scoping review of literature, 2 rounds of a Delphi questionnaire, and an international consensus meeting. And out of that, we have developed a European core curriculum, which underpinned the further training of the volunteers going forward. And the output of that has been published in Palliative Medicine and is available for you from the Palliative Medicine website. So I think if you're interested in what the core curriculum looks like in development, you can find it here in this publication. And we are working on a further publication and refinement before finally publishing our curriculum. We then developed an international training program for volunteer coordinators delivered here in Liverpool. It was a 3-day training course which happened in 2020, which kick-started the other 4 hospitals in their development of their volunteer service. So here's one of the quotes from one of the volunteer coordinators attending that meeting. So this was really to establish a group of volunteer coordinators who could work together in sharing their experience and developing their volunteer services in their hospitals. And from that, we developed an international training program for volunteer coordinators. And the big achievement was that for all 5 hospitals, we have developed and implemented a volunteer program. And that in itself, I think, has been a major achievement. And also importantly, now that we're at the end of this project, all 5 of those countries are taking forward their volunteer programs. So I think in many respects, that in itself has been a success, and also a success that these organizations have continued to work with this volunteer service within their organization. We're going to be talking about the research later, but I think the fact that these services have been seen to be valuable by the managers and leaders within these organizations is in itself an important learning factor. So I'll just mention this once, well, I'll mention it a few times, I guess, but if one of the main problems or the main challenges you can imagine from 2020 to 2024 has been that slight issue of the global pandemic. And a major challenge for our project really of delivering and developing this volunteer service has obviously been thwarted by that global pandemic. However, having said that, I think the people involved have worked tremendously hard in order to do as well as we can and to get as much information as we can from the delivery of these services. So what do the volunteers do when they're with patients? Well, these are the kind of activities that have been recorded, day-to-day activities of patients, but also supporting the patient and family when the patient is in that dying phase. And also importantly, being a presence there. And the idea with our volunteer training is not to develop mini healthcare professionals. It's actually to bring people into the hospital to have a community presence within the hospital. So it's almost to have some normality for our patients and normalization and connectivity back into the community. So we've also, as part of this development, developed a learning lab online for the volunteer coordinators to share their experiences. And the second part of our project was following the implementation and establishment of the volunteer services was to do research about this. So I'll go through these different steps in the following slides. So one of the important elements of the research was an overview of the effects of the volunteer program on the experience of dying and quality of care as perceived by patients and families. So how did patients and families respond to the volunteer presence? And for that, we were hoping to get 25 patients in the intervention group and 25 in the control group. But as you'll see, we didn't achieve that level of engagement. And that was, again, due to our pandemic issues. However, we did manage to get engagement, and we measured the data collection. Our major tool was the distress thermometer, about how much distress the patient was experiencing at that time. And we also gathered qualitative data on the patient experience of the volunteer service. So in the quantitative data results, you can see that the numbers that we had were below what we hoped for, but despite that, we did recruit from all of the countries. You can see that in total that was 105, mainly cancer patients, even split between female and male, median age of 71. You can see that we had 44% in the intervention group, 55 in the control group, and our 1 week follow-up was 54%. What we found from the distress thermometer at baseline and the 1 week follow-up was that the patients who received a volunteer in general had more distress at baseline, but had less distress at the 1 week follow-up. And those patients who didn't receive a volunteer were less distressed on baseline, and that was a lesser decrease at follow-up. So we can show statistical analysis of that, showing a strong p-value. We have to say that obviously during that 1 week, more than just a volunteer impact was here within a hospital setting. There were many confounding variables. But I think it is something of interest that this graph shows that in our group with a volunteer intervention, a decrease in distress was shown. Maybe a more interesting result is in the response shift analysis, which we did in 31 patients. And that was, the methodology for that was at the 1 week follow-up, we added an additional question, as well as saying, how is your distress at this moment in time? We said, please complete the thermometer again, and think back before you had involvement from the volunteer. So we were trying to get a bit of a before and after, a bit more of a focus on the distress here. And again, we found a very, the distress before a volunteer was about 4.77 and after 3.68, again with a significant improvement from that volunteer intervention. I guess this is important because there's a general feeling that, and we'll show you some qualitative data about the impact of volunteering, but I think that to get some more quantitative data and analysis, I think is also important. I think one of our learning points is that maybe we need better scales and evaluation tools to do this, but I think this is one step in the direction of trying to evaluate volunteer interventions. And I think in a positive sense, we have shown a statistically significant improvement. The qualitative results showed these kind of themes coming through from the patients. An expectations, human contact, someone to talk to. A human presence that eased the sense of loneliness, isolation, and boredom. The simple act of being able to talk to a stranger created a therapeutic space to openly express what they were going through. And again, some direct quotes there. So we also explored the impact of the volunteer care programme as perceived by healthcare professionals and the volunteers. So 2 focus groups were conducted in each of the 5 countries, one with hospital end-of-life care volunteers and one with health staff working on the wards. with the aim to examine the perceptions of volunteers and healthcare professionals. So what we found from the hospital volunteers was that it was a kind of distinct service. The volunteers felt they provided meaningful company and comfort to patients, and that the volunteers in particular highlighted the importance for how it was to build relationships with the staff as well on the wards in order to deliver and support not just the patients, but also to communicate back to the staff if any concerns or issues were highlighted during that patient interaction. So these volunteer activities reflected a relational and emotional orientation with a human connection, reinforcing that we didn't want the volunteers to be seen as mini healthcare professionals, but very much people from society and connecting the patient back into society. It was felt the volunteers contributed to person-centered support, responsive and attuned to existential needs. And they weren't bound by that formal care language. And it was often the little things that volunteers do that made the difference. Holding the hand, relieving the monotony, easing the isolation. So I think these are important aspects of what the volunteers can bring into that clinical setting. So the conclusion from the focus groups were that the volunteers contributed to person-centered and individualized care for dying patients. They were a unique source of community-based support, focus on existential and emotional needs, and they complement, they don't replace all clinical care. The volunteers brought the familiarity of the community into the hospital setting. It wasn't uncommon that some of the volunteers actually knew some of the patients or had previous connections with them living in their localities. So the further work identified was to embed this role and scope within this unique environment, and also to look at the cultural differences across the different countries. So as an important part of this project, a dissemination of findings, and to date, I've mentioned already the publication in the Palliative Medicine from the Delphi study. There's also an impending publication around the facilitators and barriers to implementation of hospital end-of-life care volunteer services. We also have conference presentations, 12 in all, 4 oral presentations and 8 poster presentations, and also planned publications around the end-of-life care volunteer and healthcare professional experiences from the focus group work, the publication of the contents of the European core curriculum and development of that, and also the paper on the effects of the volunteer programme on the quality of care using the qualitative and quantitative data. So that summarises the kind of scientific outputs from the programme. The other aspect I thought I would mention, and Claudia, I don't know, I'm not everybody who's online. Claudia, I can just see you are there. So I'm going to mention the health economic analysis that took place alongside the volunteer programme. A lot of work went into this, and I'm going to try and summarise this. Any questions or discussion, we can include Claudia, who's our expert here. But we tried to look at what the costs were of implementing and not implementing the initiation of the service, but also the sustainability of the service, and also what the costs or the benefit costs of having a volunteer service were in that environment. And these are the kind of things that were taken into consideration, including the salary costs for the development and implementation, operating costs, and the assumptions that volunteers were not compensated for their time. and they were valued at an average country-specific nursing salary. So the results really around the service development were the cost significantly varied between countries. And that's because in some countries, people had employed specific people to do this. In other countries, it was absorbed into people's current roles. So the way countries interpreted the costs of setting up and establishing this did vary considerably, and you'll see some of those costs as we move forward. On average, across the countries, 15 volunteers were trained, and the cost ranged from 3,000 Spain to 15,000 Norway. And the majority of those costs were staff costs. The service operation, again, a large variation from 4,000 to 41,000, and annualized total post-COVID volunteer activity ranged from 44 hours to 474 hours. Again, the amount of volunteer service delivery, I think we feel moving forward will increase in all the countries as the volunteer services become better established. And that UK number there of 474 is probably a better representation of what's achievable. So the operational benefit cost ratio, the BCR, is linked to basically the cost of the training and service delivery compared to the payback from the volunteer service. So a score of less than 1 shows that the operational costs outweigh the generated operational return. Greater than 1, the operational return exceeds the operational costs incurred. So here, if you look at based on the level of activities, you see a positive BCR for the UK, less so in other countries that had higher costs of starting and sustaining the programme. But when we look really moving forward and maybe looking at what we think is the potential of these services, we think a best case scenario could be a BCR of 5.4 and the worst case scenario of 0.5. So if this works well and is implemented and is integrated into people's role, the payback is 5 times the investment. The worst case scenario is you get half of your investment back. So the break-even case is for 106 hours of delivery of volunteer service in the Netherlands, which would be to over 1,000 in the costings in Norway. So I think, again, this is the first step into health economic analysis in volunteering. A full cost analysis wasn't possible because of the level of data, but I guess this gives us a baseline, and it would be very nice for us to revisit this baseline when we've established these services more fully, to look at the operational costs and the hours delivered by the volunteers. Because I think we'd be then very much on the best case scenario, being on that side of certainly getting more for our investment. And this kind of information and language is important as feedback, particularly into our managers and leaders of healthcare systems. Hopefully that is some helpful health economic analysis. So finally, from our project deliverables, you can see the things that we're delivering back into the EU, including our core curriculum, including our training program for volunteer coordinators. We're developing from the 5 centres a reflection piece on the implementation and the challenges of implementation in the 5 different countries. That paper we're going to publish shortly on the factors influencing the implementation, and then the research studies that I've outlined to you and the publication that will emanate from those. And we have to deliver at least 1 submitted paper and an abstract, which I've already said that we've achieved. So that just gives you some of the framework for how we deliver this back into the EU, and the resources that will be available in the next year or two ahead. So a big thank you to all those who took part in this project. I'm reflecting the work of many people out there. Some of you are on the call today. I think to achieve what we've done, despite the COVID pandemic, has been remarkable. I think it was an ambitious project without the pandemic, but to have got to the end of this project, to have actually got some quantitative and qualitative and economic evaluation that we can share on a global basis, I think has been a real achievement and is a great platform for future work in this area. So I'd now like to hand over to two of my colleagues to really share and reflect on their experience of taking part in the project. So the first person to do this will be Tamsin McGlinchey, a researcher based here in Liverpool. So I'll stop sharing my screen and hand over to you, Tamsin.
Hi, thank you. Yeah, as John said, my name is Tamsin McGlinchey. I'm a research assistant here in the palliative care unit at the University of Liverpool, and a researcher on the iLIVE cohort study and volunteer study. So just kind of a few reflections, I think. And in thinking about my own reflections, I came across a reflection from Dr. Naomi Richards, who's based in the University of Glasgow, and she's recently sort of led on a recently completed 4-year study, which looked at people's experiences of dying at home in a context of financial hardship and deprivation in the UK, and that used participant photographs that they took to document their experiences. And there's a little bit of a quote from her where she said, "I was jealous of colleagues undertaking theoretical studies or creative writing projects with just them and the page or screen in front of them." And she also said that at times she felt she wished she had designed a less experimental study. Perhaps maybe Agnes van der Heide and John Ellishaw and other senior researchers responsible for the iLIVE project may have felt similar to Dr. Richards at various points throughout the iLIVE project, but then that wouldn't have been pioneering, would it? So Dr. Richard also noted that with novelty comes challenges, not least with gatekeepers. So, for example, trying to overcome reluctance and reticence from healthcare staff who were sort of unfamiliar with the study and apprehensive about the project, and apprehensive about the prospect of it for their patients. I think we sort of also recognise this, I think, within our own research team here in Liverpool. And I think from a researcher perspective, gaining that trust, support and good faith of healthcare professionals was a really key part of optimising our own recruitment for this study. And we did kind of learn so much about the importance of, I think, perseverance, of keeping going, going back into the clinical environment, being a visible face of the research, being positive, also not being put off by apprehension, but to embrace it and so not be afraid to keep answering questions and being patient. I think when you have clear tracks to follow from kind of previous studies, it can be easy, I think, but we were kind of making a few new tracks with these projects, especially the volunteer study, and sort of involving patients at the end of life in this kind of study is relatively novel, and I think we're still not fully sort of confident in it, in kind of the approach maybe. And I think what made the difference was for us was and for me in kind of being on the ground and recruiting was a kind of regular updates to the clinical team about recruitment and feeding back our experiences of recruiting patients. And I think staff slowly became sort of less afraid of broaching this prospect with patients. And so talking of sort of feeding back experiences of recruiting patients, I think this is sort of one of my most important reflections, I think, on the iLIVE volunteer study, well, as the iLIVE project as a whole. I think that we did recruit patients. It was possible. I think sometimes we can forget or underestimate kind of, I guess, the bravery and willingness of patients to take part, and their desire to share their experiences to help others in the future. I think despite the sort of sensitivities of topics in the questionnaires, the often sort of quite significant physical discomfort and decline that the patients were experiencing, many of them did want to take part if they could. I think we need to be really aware of this and not marginalise voices of dying people because we assume it might be too upsetting or too much for them to take part. You know, it is challenging, and you have to be very conscious of being ethical in your approach. But it's important that patients have the opportunity to say no. We did have many that said no, but not all. And for some patients, they did decline because it was too much for them to take part, but others could. I think this kind of naturally, I think, reduces numbers of patients we may be able to recruit, but makes their voices and experiences, I think, all the more kind of precious and valuable. And you know, we need to make sure we get them and we use them really well. So I think that's kind of my main reflections from the study. Thanks.
Thanks for that, Tamsin. And certainly for the researchers, the limitations with COVID were a real challenge as well. So thank you for that. So over to Greta Skorpen now in Bergen. And Greta, you led the implementation in Bergen. So grateful for your thoughts and reflections.
Yes, thank you very much for the opportunity to share some of the reflections. And I was had the privilege of being one of the 2 coordinators for the project in Bergen. And I must say, to be able to work so closely with the volunteers, and seeing how eager they were to learn more and to just to jump into this after the training and to give their time as a gift, it has been really, really rewarding. And I just met a couple of them this morning, and they are still very eager. And every time they see me, they ask, "Do we have any assignments for today, or have there been anything last week?" And I don't know if you can see, I have a badge on my blouse today, and that is also a kind of a badge to symbolize the work these volunteers are doing, because at our hospital we already had a general volunteer service up and running, and so this was an additional part of the service for a small group, a very kind of a hand-picked group, so to speak, because this would definitely not be for everyone to do this kind of volunteering. And yes, I also think for us as volunteer coordinators, it was extremely important to have the map, the core curriculum, and the opportunity to meet for the trainers together. And luckily it was just before the pandemic, because then we had a lot of things to work on. And of course, one of the biggest thing was also to keep the motivation up for the volunteers. And we have managed to keep the motivation up all the way, and we still have, like for the Norwegian side, we still have most of the trained volunteers active in this group. So we are very happy for that. I think one of the biggest challenges have been to keep the wards updated at any time. Of course, we did a lot of information before the implementation, and to let them understand what can a volunteer do and what can a volunteer not do. So they will really understand that the volunteer is, like you said, John, not a semi-nurse or anything, but a fresh breath from the community, and with no agenda to come there. And so that's been very important for us to go there continuously, so to speak. And I think that's one of the main areas to keep going with the information to the ward, so they don't forget that this is an opportunity for them. And another thing is perhaps that we can see that the patients are very ill when they are at the hospital, and especially for inclusion in the study, it's been difficult for us in Norway at least. So we know that when they are at the hospital, they are very ill. They have a lot of things to do perhaps before they hopefully can go home and live their lives at home or in the nursing home or where their residence is. So that has also been kind of a tricky point. And perhaps also due to the pandemic, a lot of people have been afraid of if I'd say yes to a volunteer, will that mean that I will not be able to have my relative visiting, for instance? So that's been one of a kind of an issue as well, especially from the nurses at the wards, that they have been a little bit afraid of that kind of gatekeeping in a way. So for us, we know it's important to be visible all the time, and it has also been really rewarding and important that the volunteers have met with the other countries. So the 5 countries have had supervisions together online. That has been very important, because if you don't have many services things to do this week, it's very interesting to hear reflections from the other countries and their experience, so you can share them as well. And also the same for the volunteer coordinators. It's been important that they also had meeting points online, and also in the learning lab, particularly during the construction and the building of how do we do the training per country. So in a way, we have had the same map to navigate from A to B, but due to local topography, the path you've been walking have been slightly different. But altogether, it's we have all reached the end point and the same goal within the 5 countries. Yeah, thank you.
Yeah, thanks, Greta. Nice to hear that real life experience of developing and implementing the service. We've got a couple of questions in the chat, which we'll come to in a moment. But if anybody else has questions, you can put them in the chat or put your hand up and we'll come to you. Nice to see you, Harriet, on the webinar. Welcome. And you've got a couple of questions. Do you want to kind of to ask why do you say them out loud, and then we'll pick them up and have a discussion? Yeah.
A bit more interactive. So firstly, thank you. This is amazing work, and especially during the pandemic. I had a few different questions, really. So just for context, I'm based at Mount Sinai in the US, and thinking about we already have a volunteer program, but thinking about kind of standardizing it a bit more, looking at the European core curriculum, some of the training that's been done as part of this project, and start to do kind of our own evaluation in the US, which is obviously a very different health system. So I'm interested in terms of how the volunteers are actually communicating with the healthcare teams, if at all, and whether kind of advocacy is part of their role. So a lot of the challenges we have, as I think we have in Europe with our patient populations, is really getting their voice heard in the context of a hospitalization, particularly near the end of life, particularly when they have serious illness. And I think there could be a real opportunity, certainly in the US, to have advocacy with the healthcare teams as part of their role, because often there's a power dynamic, and often people don't feel empowered to kind of share their concerns. But having somebody who's coming in from the community and really in their corner, I think could be incredibly powerful. So that's my first question. And my second question is really, and this has come up in some of the discussions that I've been having here around, are there, where it's feasible in terms of if you have a large volunteer service, does anybody have any experience of kind of, and I know this has challenges, but quote unquote, matching volunteers to patients and families, where there is kind of a real heterogeneity in people's backgrounds and people's communities, where they're from, etc. And I wondered whether people have experience of that. So those are kind of my two kind of practical questions. And my research question really is around the use of post-death bereavement surveys, which I know have challenges. But is there a thought of whether or not, rather than kind of using more general quality of life measures, we could see more responsiveness to change with kind of a quality of death and dying questionnaire? So 3 separate questions.
Okay, so maybe we'll pick that up in different ways. So maybe in a moment I'll come to you, Tamsin. Maybe if Agnes is there, we could talk a bit about how we looked at the bereavement aspect in the cohort study in the code. So maybe have a bit of reflection on that. But first, maybe we'll come to you, Greta, and then maybe to you, Emily. Emily Naylor is on the line, and she's our volunteer coordinator here in Liverpool. Just for your reflections about, I think for me it's partly advocacy, but it's also how you develop that relationship between the volunteer and the staff. So how, and part of that is about the staff thinking, are they here to take over my job, or they just get in the way? So to me, there's almost 2 steps. There's one about how you get acceptance with the clinical team, and then how you enable maybe the volunteers to feed back in an advocacy way to the clinical team. So I don't know, maybe the matching of volunteers to patients. So Greta, any reflections on those practical aspects around the volunteer role?
Yeah, thank you for the good questions. For the matching, yes, my colleague, she tried to do the matching if possible, depending perhaps on interests or what kind of what do the patient want. For instance, one wanted help to write his life story, and then it was helpful to have to one with a fast fingers on the on the tabulator. So that's one part of it. And regarding how they communicate with the healthcare team or the staff at the wards, they always have to knock on the door on the staff room to get an introduction and to be guided into the room, and also to call the staff when they are leaving the room, for instance. So they need just to know what do I have to make sure I'm doing right. The advocacy part, I'm not quite sure if I've seen that very clearly from my perspective so far, but I have one important thing, and that is one of the volunteers was sitting with a dying patient, and then he reflected back in the group afterwards. How would it be if I was not able to sit there? Would the person die alone, or would the staff have been there, or how would that be? So in a way, that could be that was a kind of an advocacy, because it was very important for him to make sure that no one would die alone unless they explicitly had asked they wanted to be alone. So this was something we discussed and reflected on, both locally and also across the 5 countries. Yeah, please supply, Emily.
Emily, anything you would like to add in addition to that?
Yeah, thanks, John. I think it's really important for volunteers to have a really good relationship with all types of clinical and healthcare staff within the hospital. We're very fortunate at Liverpool. This is a service that we've been running for a long time, and so those relationships have been built really well. I would say in the first instance in introducing the service, and I assume Greta and others may have found the same, that there was a little bit of reluctance from the staff, but we're certainly at a point now where staff really see the benefit of the service have a really good relationship, and we not only work closely with the ward staff but also our palliative care team, our SWAN team and our bereavement nurses, and they're always really keen to kind of involve our volunteers in that patient-centred care and get in touch with us if they've got patients that they feel would benefit. And it's very much kind of at the forefront of thinking and planning on how best to support our patients in the hospital. So yeah, I do think it's really important that that the volunteers and the staff, do communicate well, and that we have a really good working relationship, not only volunteers with the volunteer service and those staff as well, obviously caring for patients. We don't tend to match volunteers to specific patients in Liverpool. If we get a specific request from a patient, then we will always try and kind of support that. We do find that certain volunteers may build up relationships with certain patients, especially if they're in the hospital for a number of weeks, and they might each week when they're in volunteering go and check in and see that patient, and then build a really good relationship. We had when we were in the old hospital, one of our volunteers had a similar career and background to one of the patients, which they just kind of stumbled upon when talking, and so the patient really loved those times spent with that volunteer to kind of reminisce and share those experiences from his working life. So yeah, really important. But the volunteers absolutely love doing this role, and really do feel like there's an impact on to the patient, but also to the staff as well. I think for the staff, knowing that patient isn't alone, there's a volunteer with them, especially for patients who don't have family regularly visiting, and may not necessarily have someone with them at the end of their life, and having that volunteering as an option to offer that support and that additionality to what our clinical staff are doing. I think very much so now our trust is seen as huge value, but that's taken obviously time to kind of build that trust in. Yeah, thank you.
Thanks, Emily. We've got Tony, we'll come to you in a second because you've got your hand up for the question, but we'll just get some maybe reflection on the tools used in bereavement and what was used in iLIVE. Tamsin maybe first, and Agnes maybe, or Agnes, maybe Agnes, you have look, I'll give you a rest, Tamsin. We'll go to Agnes.
Thank you, John, and nice to hear your very clear and interesting presentations about the volunteer study, and also the reflections were very interesting, I think. As John told you in his introduction, the volunteer study was part of a bigger cohort study in which we collected data about over 1,400 patients in 11 countries. So those patients in the 5 countries that were involved in the volunteer study, and the patients that participated in the volunteer study were also participating in the cohort study. And for the cohort study, we did a bereavement assessment among relatives of those patients who died during follow-up. And those relatives were asked to complete questionnaires about how they appreciated care in the last days of life and about their own bereavement process. We used the I-code questionnaire for that, and also some scales of the Hogan bereavement questionnaire. I don't think we have already assessed whether we can use those questionnaires to also see if involvement of a volunteer made a difference for relatives' appreciation and bereavement process, but we are definitely going to look at that, whether we can use those data also to evaluate relatives' experiences.
Thanks, Agnes. Okay, Tony, can we go to you, because I feel you've been sitting there with your hand up. I know you haven't been, but it looks like it. So over to you. Any thoughts or comments?
All right. Several observations, John, if I may. It's a while since I've been in touch with you and your services. It was many years ago. And I want to start off with a reflection from someone who was volunteering for me many years ago, who he said he loved doing it because he didn't like the thought of people dying on their own. And so that was quite an important thing. Just several random things, really. First of all, the chaplain, there's a the chaplaincy role, which might be faith specific, I wondered if there was any kind of crossover or tensions or liaison, if you like, with the chaplaincy. Actually, so perhaps I'll just tell you a little bit about myself. I mean, I've been a member of Motor Neurone Disease Association for over 30 years and visited dozens and dozens of people, you know, over the time of from their diagnosis to death. And so that's part of my experience. And I take people to Lourdes on pilgrimage, and many of them have been palliative and towards the end of life as well. So just to say about the importance of knowing, having a good diagnosis of and prognosis accurate, and how it's delivered and how that affects people's level of coping, if you like, and how important it is to know more accurately how long someone has got to live before the service can either start or accelerate, or perhaps even be terminated very close to death, for example. And I was just interested also in the demographics of the folk who die in hospital vis-a-vis those who are at home. So are there any key features of which you may have noticed? The numbers may have been comparatively small. And I just wondered also what the health condition of the people are who died or who are dying. Maybe the answer is multiple comorbidities or something, but sometimes if it's heart failure, or if it's a cancer or something, if that in any way affects the role of the volunteer and how they deliver it. And perhaps just lastly, John, maybe controversial, but the use of something called a distress monitor. I've always been, I'm sort of quite positive about death. It might sound awful about to say it that way, but to rather than assuming distress, and it kind of feeds into sort of, you know, people are in pain and all sort of thing, and arguments for euthanasia and all sorts of things like that come in. I just wonder whether something more even-handed in terms of monitoring feelings towards the end of death might be more appropriate. Thank you.
Yeah, just I'm just looking. I'm aware of the time, because for that we could spend a long time talking about all those things. But thanks for bringing those points to us. From my perspective, the volunteer services work closely with our chaplaincy services, and they're very complementary. I don't think we've had big problems or conflicts there. And in fact, for some of the volunteer services, part of the training is from the chaplaincy team themselves. So I think they feel very much part of and integrated into this service. I think the kind of patients that we have focused on in this study in iLIVE for our work package 3, it was those in the last weeks of life. It was towards the end of life, but our volunteer services, I think, increasingly for end of life, working to those patients in the last months of life, and in multiple, you know, it's not disease specific, it can be any kind of disease or comorbidities. And I do take your point about the distress thermometer and the language around it, but I have to say that I think I mentioned that one of our learning points was actually having validated, reliable tools to really measure what we're trying to capture here don't exist. And that's led us to go, as our next step in research, is to be thinking about developing some tools that maybe could capture the activities of this kind of service more appropriately. Because if we continue to try and measure things with tools that aren't appropriate, we're not doing a good job. But to develop these tools is quite a big undertaking and takes a number of years. So I think this is something that is a gap and something that we do need in the system.
Thanks very much, John.
Okay. Thanks for that. Okay, I'm aware that we're coming to the end now. I think it's been a really really interesting webinar from my perspective. Nice to hear those others' perspectives. I see in the chat the idea that we should be doing this into care homes and examples of that, I think. And I think there's some interesting discussion going on there. So nice to see people contributing to it. I would like to thank everybody for their contribution and attending today. Obviously, the International Collaborative has a wide range of activities. Please visit the website to share in those and to maybe get more involved in the collaborative. And just finally, to promote our next webinar, which links with motor neurone disease and care of the dying person with motor neurone disease. And that's going to be led by Professor Peter Aldcroft from Adelaide, Australia. And you and your colleagues are all very welcome. So thank you all once again. And I hope you will follow our publications and join us in our interest in this very important part of care for patients and their families. Thank you. Bye now.
Thank you, everyone. Keep up the good work.